Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hey there, everyone. Welcome to the next episode of the Skin Sync podcast. This is Shannon Moranti.
And this is Buccinita.
And we are so excited to come to you today with some information about dermatology conditions without cures. There are so many skin conditions that we see every day that do not have an FDA-approved treatment. Or if there are, treatments that have been used for decades, sometimes they're not always reliable and they need some tweaking. So Bucci, I would love to pick your brain today about how you approach some of these conditions and how we as dermatology providers can provide the best information for our patients and also kind of come to them with, we don't have all the answers and there is no cure for this condition, but we're going to do the best job that we can to calm down whatever it is that's going on and give you the best therapeutic options that are currently available. So Bucci, let's talk through some of these conditions. What is the first condition that comes to mind when I say a common condition that does not have a cure?
So let's talk perioral dermatitis. There is probably not a day in clinic where I don't see this. Either patients are coming in with the complaint about this rash around their nose and mouth. Sometimes it just presents and we happen to notice it. But very difficult to treat in a lot of patients. My patients are predominantly younger females. Is that the same in your clinic?
Absolutely.
Right.
I think young females are the predominant patient type for this condition.
Right. And so, and oftentimes the foundation of this conversation for me is skincare, of course, because sometimes they're just doing too much. Like, stop all the products, stop all the toners, the astringents, the masks, just stop it. So I literally tell them,
the vanity.
I tell them to stop all of it. And we are going to gentle, basic hydrating cleansers and moisturizing agents. I like some of the kind of healing balms like Cicaplast and Ciclefate. But as far as management goes, my favorite combination has been oral antibiotics with topical TCIs. So pimecrolimus is my absolute favorite one. I use it twice daily in patients until they're completely clear and usually for a few weeks after. And I also like either doxycycline, sarecycline, and even low-dose minocycline I've been doing quite a bit of lately. So that's my go-to regimen. Seems to work great for me. What's your recommendation for perioral derm?
Love all those recommendations. I always love to start with truly sitting in their frustration with them because they have come to us after literally trying everything, including the kitchen sink, and being so frustrated and then waiting for the appointment to come see us. So by the time they get to us, they are weeks to months into this condition. And I like to tell them, you're not alone. Everybody fails at this. Not a lot of people can handle this on their own. So I'm sure you're doing a fantastic job, but whatever you're doing is not working. Okay, so stop it. Stop everything that you're doing. So I do the exact same thing. I say stop, and we need to completely change directions. I need to make sure, number one, that they discontinue all topical steroid use. Because I find sometimes patients are like, oh, but I'm only putting that clobetasol on my bug bites, on my ankle, or no, I'm using something on just my left elbow 3 times a week. Yeah, but then you're scratching your nose and you're getting it on your nose, and then you're rubbing your lip and you're getting it to your face. So I make sure they stop all topical steroids if they can. If they have a non-steroidal option for their AD or for their psoriasis or for their chronic inflammatory condition, I really try to get them off topical steroids for a short time until we quiet this down because I explain how that can totally flare this condition. I also love those oral low-dose extended release doxycycline and minocycline options. The new rosacea low-dose minocycline has been fantastic.
It's fantastic. It's a great product. Yeah.
It's been awesome. It's once a day. I don't have to worry about it totally destroying, gut microbiome. So patients love that. I also love a good sulfa wash, either a prescription sodium sulfacetamide or the 111 Med Company has a sulfa bar soap, which is pretty awesome, especially if they are, really flaky, really itchy. I typically find there's kind of 2 baskets for perioral derm. There's more of an acneiform perioral derm, and there's an eczematous, itchy,
Yes.
flaky, dry. Do you
100%.
agree?
100%.
Yeah. So for my patients that are like acneiform or rosacea prone and have a lot of like acneiform lesions and papules and pustules, I love to go with some of the acne or rosacea products, clascoterone, dapsone, or that topical minocycline foam. We all know that yellow
Yeah.
foam that
Yep.
was FDA approved a number of years ago for both acne and rosacea. Work great for the acneiform perioral derm. For my eczematous, rashy, itchy perioral derm, I'm with you, girl. I love pimecrolimus. I love the non-steroidal eczema
Yep.
medications, believe it or not. I feel like they all do a great job. So I've used roflumilast, tapinarof, ruxolitinib if I can get them covered,
Yep.
or if I can sample patients through, those couple weeks. I think that just calming that inflammation is really the key to success with perioral derm. But also explaining to them that even if we use everything, it's going to take 8 to 12 weeks for this to go
Yes.
away.
And I think that's the most frustrating part for me and for them is that this does not go away quickly. You're in
Right.
this for the long haul, so be patient,
Yep.
please.
Exactly. And aren't patients are not
Yes.
always
No,
patient,
no,
as
I'm
we
not
would be
either.
if we were
Yes.
in their
I'm not
situation.
either. All right, so let's kind of jump into another very common, slightly embarrassing condition that has really the stigma associated with it is herpes simplex. And not
Yeah.
just the genital type, but the oral herpes simplex still has this really
Yes,
strong stigma. So let's
for
talk
sure.
about it. What are your go-to treatments? How do you
Yes.
diagnose it? If it's, do you get the confirmation in patients? Do you do testing, swabs, lab work? What's your protocol?
So we all know that there is no cure for herpes. Herpes is the gift that unfortunately is with you for life. And nearly half of all adults in the United States, 48%, currently in the United States, have HSV1, whether they are symptomatic or not. About 12% of adult patients in the United States have HSV2. And we know as providers that HSV1 does not always live above the waistband and
This is true.
HSV2 does not always live below the waistband, right? There is a lot of movement, there's a lot of
Intermingling,
shifting,
yes.
there's
A
a lot of
mixture.
migration. They're
Yes, there
always
you
on the
go.
move. But when HSV finds a home, it typically lives there, forever. So wherever its home is, that's its forever home. It finds those little nerve endings. It finds those cells in those areas, and it loves to live there for good. HSV1 is increasingly becoming a cause of more genital herpes cases in the United States. There's a lot of rising rates among this non-monogamous younger adult generation. So this is definitely a big problem. And although I think we thought we had kind of thwarted the HSV2 issue a number of years ago, I think there are more cases that are on the rise. So I think the providers out there really need better education on how to educate their patients and how to explain this condition to their patients. So I know this could be an episode all in itself, Bucci,
Right.
but how do you counsel, quick counseling tips? Do you recommend testing? Like, is that something you do?
I don't. So, unless there's a diagnosis that I'm unsure of, or maybe it's a mix like herpes simplex with a little bit of, impetigo in there, then I'll do maybe a PCR. I don't do a lot of cultures anymore because PCR to me, it comes within a couple of days. The results are
Yeah, for
quick
sure.
and we can test for everything like viral, bacterial, fungal. So that's about the extent of the testing that I do. And sometimes it's really for the patient. Sometimes it's not because I need the confirmation. It's because the patient
Right.
needs the confirmation.
That's
And
so
it
true.
just kind of helps them settle into that diagnosis. So that's typically my protocol. And then when I counsel them when it's HSV1 or at least oral herpes simplex, I usually give them the reassurance like you were probably exposed to this as an infant, as a child. Most of us have it. It's extremely common. It's something that we can manage, pretty easily with topicals and or orals, usually oral agents. So we counsel them on making sure that they try to pay attention to those symptoms. And the minute they feel that tingle, that itch, that burn, that sting, that they get on their therapies, my favorite being oral valacyclovir, to try to knock down that flare, or at least clear it up a lot faster. So that's typically it when it comes to herpes simplex in the genital region, sacral region, gluteal region. That's a
Yep.
much more difficult conversation.
It sure
And what
is.
I usually tell patients, just because it's the reality of it, we really don't know when you were exposed to this. And I can
That's
give
so
them a
true.
sense of when it may have happened, but we don't know for sure. And I don't want them to have this guilty feeling that they're dirty, or I just really don't want to have that stigma associated with it. So I just tell them it may have been years ago, your body may have been under stress, and that's why you're flaring now, but we're going to make sure that we keep it under control. So that's
How
my
many
go-to.
times do you have patients come in and say, I get this recurrent spider bite in the exact same place, like right above my butt crack, right at my lower back. And it seems to happen every year when I get stressed out. And my response is always, well, how did that spider know to bite you in exactly the same spot
I
every
love
year?
that. I
Or
absolutely
they're
love that's a
blaming
great
shingles. You
recurrent
know,
shingles,
I
guys. That's not
don't
it.
think. And we have to go through the entire education piece about how shingles does not recur
Yes.
annually every time your in-laws come in town and
And honestly,
every single time you get stressed out. I think sacral herpes is such a embarrassing diagnosis
it
for
is.
for patients, but it really behooves us, to treat it adequately and to make sure we are giving patients the proper diagnosis because if they, get into a new relationship, if they know how to manage this disease and there are ways of treating it, not curing it, of course, because this is a disease without a cure, but there are ways to manage it to where they can use not only episodic therapy, but preventative therapy. And I think that's so critical, especially for patients that are in, multiple sexual relationships. If they are, a big fan of Tinder and, again, no judgment,
No
but if
judgment.
they are
No
out
judgment from
there
us.
having some fun. You need to
Just
be a
protect yourself. That's all.
responsible, sexually active adult and make sure that you are on a therapy that can prevent that viral shed and spread to other patients. Another group of patients that are really at risk of spreading this to others are athletes,
Yep.
especially wrestlers. We all have heard of the condition herpes gladiatorum, which is HSV that can occur typically head, neck, back, shoulders, and can be terribly disseminated when it first erupts, especially for a young male athlete that's never kissed a girl. And then he's, wrestling against the senior that has kissed every girl in the cheerleading squad. And he's, breaking out in these terrible, terrible blisters. I've had so many young men come to me misdiagnosed as
Yep.
staph and
Absolutely.
they went to an urgent care, they were put on an antibiotic and their lymph nodes are swollen, they feel like crap. So it's definitely something that we have to manage appropriately and give them the adequate diagnosis. I am 100% with you. I agree. Valacyclovir, famciclovir are my go-tos. Do you, Bucci, recommend L-lysine? The enzyme is kind of a holistic recommendation for the chronic management of herpes simplex.
I really don't. I've heard about it over the years at different conferences, read about it before. I just love valacyclovir so much. I haven't found
Yeah.
much reason to incorporate it. However, I know that it can be really helpful. What's your advice on that?
Yeah, so I certainly think it's a supplement that cannot hurt. Right. And if patients come in asking about it, I don't always, put every single patient that I see on it. But if a, mom of a wrestler wants to know, hey, how can I, this went around our kids' wrestling team last year. How can I prevent my young son from getting this? We can put them on prophylactic therapy of valacyclovir, half a tablet every day. And L-lysine is something that studies have shown may reduce the frequency, severity, and healing time for HSV. But the scientific evidence is mixed because there's no formal studies on it. So there's preventative recommended dosing about 500 to 1,000 milligrams per day. For active outbreaks, you're supposed to take 1,000 TID. Theoretically, they could take it around the same time as their valacyclovir for about 7 to 10 days. What do you think about Abreva, the docosanol? Do you recommend that at all?
I
I mean, I
really
know a lot of
don't.
patients come
And
in using it.
yeah, I don't recommend it. I don't feel like topicals as a whole really work great for HSV, oral or genital. It's not in my recommendations. How about you?
And I think part of the counseling we need to do for patients is that it is the only FDA approved non-prescription product out there for HSV, one for cold sores. However, it's classified as an antiviral because it prevents that virus from entering the healthy cells, but you have to use it like 5 or 6 times a day. If it is not constantly actively applied, that virus is going to get in there. And that docosanol just did you no good at all. So I know it's expensive. The tube is like the tiniest tube I've
Yeah.
ever seen in my entire life, and I know it's not cheap, so it's not something that I have in my repertoire. What about some other good recommendations for conditions without cures, Bucci? What do you
So
got?
I'm going to cluster all these together because the therapy that I've been utilizing has been the same. But for patients who have generalized lichen planus, which I see a lot of, I don't know about you, Shanna, but I
Yeah,
see quite a bit of LP.
yeah.
Generalized granuloma annulare, I see a decent amount of that. That's probably the most frustrating thing to me because I'm like,
Oh, for
what is
sure.
causing this? We have no clue.
We have no answer. It's so
No answers. Very,
frustrating.
very frustrating. And lastly, morphea. I don't see this one quite as often, but it can be really difficult to treat again, especially when it's more generalized.
These are
Oral
all
jack and
three very
all
difficult
three. Very,
conditions
very
to treat.
difficult.
None
Yes.
of them have cures, and all of them are frustrating for dermatology APPs. So, what do you got? What do you use for these three?
So, of course, I sometimes will go through all the typicals, your topical agents, intralesional alkenologue. Maybe we'll do methotrexate for patients who are candidates. But lately, I've been having wonderful success with the oral JAK inhibitors. I am very much leaning away from systemic steroids for these conditions like we used to do years
Oh,
ago. But oral JAK inhibitors have been fantastic. Upadacitinib, I've been using it quite a bit in some of these patients because we have samples.
yeah.
And it's been working extremely well. Getting it approved by the insurance has been near impossible. So unfortunately, I don't have
Right.
any tips for that. But I've been finding it
Oh,
highly effective, very well tolerated. I actually did get a patient. She had morphea, and we got her approved for a JAK, but she also happened to have RA and atopic dermatitis, so it worked out well.
but it
But
helped her morphea, I
it helped
bet.
her morphea. It helped her morphea very quickly, actually. Within a month, she was
Wow,
dramatically better. So if you
that's
guys have
great.
not utilized the oral JAK, abrocitinib, upadacitinib, some of the others, it may be worth a try if your patients are candidates for it, don't have any significant medical history that would be a contraindication. Definitely consider the oral JAKs in these more generalized conditions. So,
Those are great tips. And I'm sure you go through like medical history, and I'm sure you go through your whole, Jack mantra, which we all
yes.
have, down to a science at this point. But super, super helpful for those patients that really are struggling to find a therapy. Because you're right, topical therapies have failed them. Even intralesional steroid options have failed them. Or if they're so generalized, like I have patients with generalized GA, there's no way we
No,
could inject every single one of those lesions.
not
So,
at all.
of course, they need appropriate workups. Of course, they need to be sent out and make sure their PCP's on board and make sure you have those good conversations, with collaborating providers to let them know your thoughts and let them know the science behind it. Do a deep dive in the research and find some case reports, find some case studies that have shown good value. When you're looking for a non-FDA approved therapy, it's really, really important to document your course of action. Because unfortunately, when there's not an FDA approved study, like there is not in a lot of these conditions, we have to be very careful to cover ourselves and make sure
Right.
that our patients are protected and they understand all of the nuances of the therapies that we're recommending.
And sometimes I'll actually print out some of the publications for the patient. And I explain, obviously, it's very medical jargon, but I want them to have that information just so they know. So, and then one condition, Shanna, I don't hear a ton about it at conferences. I don't see a lot of publications about it, but I see it a lot of the times in clinic is notalgia paresthetica. Is this something you run into often?
Ooh, I see this all the time. And this is
Yes.
so frustrating because there's no perfect magic wand for this condition. Ooh, what do you recommend? I can't wait to hear this.
So I'll do this sometimes. I don't always find it effective, but over the counter capsaicin. So this is derived from peppers and it just kind of helps, I think, to deter that nerve sensation when it comes to itch. Caution is advised with capsaicin cream because that first application can be quite uncomfortable. I had one patient who was angry at me because it burned her so much. She refused to ever use it again.
Oh,
So that was one patient. But generally, I warn them about the stinging and burning. You do not apply it to open skin, but it really can help kind of disrupt that itchy sensation when it comes to notalgia paresthetica. Another product
another
of yes,
great, and oh, excuse me.
go
Let me
ahead.
let me cut in here. Another great topical would be a topical called Dermaleve, which is available
Yes.
over the counter on Amazon. It's a strontium-based product. Strontium is in the periodic table of the elements. So for those science nerds out there, they will love the fact that it is kind of organically derived, what have you. But it can disrupt itch as well and works quite well for notalgia paresthetica if the patient can reach the spot on their
Yes,
back
that's the hard part.
where they're
So have
itching.
them get a back applicator. Amazon, it's like $7, a little pad with a handle attached. Put some cream on it, rub it on your back. It works pretty well. I've had people use a
Right.
spatula before. That's interesting too.
For sure. Yeah, I've heard
And
that too.
Dermaleve does come in a liquid solution that you can use on the scalp, and it does have a cream as well. And then a couple interesting things that I will recommend as we close out: physical therapy or seeing a chiropractor. We think that this condition may be associated with nerve compression along the spine. And so perhaps seeing someone that can help to decompress that nerve or alleviate that muscle tension may help notalgia paresthetica. I've had a few patients who've had some success with this. And last but not least, Shanna, that this is news to me, there are exercises that you can actually do for your upper back, for your shoulder, to improve your posture that may actually help notalgia paresthetica. So if you go online,
I love
yeah, there's actually
that.
publications about it. It's recommended, and this may also help with scalp dysesthesias as well. So patients with that chronically itchy scalp with no cutaneous rash, you may consider trying these scalp and neck exercises to help reduce the itching. So
That's
that's my go-to.
fantastic.
Yeah.
And for patients that really don't want to go down a pharmaceutical route or can't apply, maybe they're very limited in their mobility and can't apply products to their back, I think that's a fantastic recommendation. I love the chiropractic shout out here because I have had patients that have been completely relieved of their itching from either notalgia paresthetica or that brachioradiopruritus,
Yes,
that
yes,
they get
yes.
from the nerve impingement of that cervical plexus. So definitely think of your anatomy. Make sure that we are explaining this to patients and know when to phone a friend. And if you do believe that there are some nerve compressions going on, definitely shout out to our colleagues for help.
So Shanna, I could do this for hours because I've got at least 10 more conditions that I can think about
I
right now.
know. We're going to need
But
to do another
yes,
episode.
we're going to save that for another episode, but I appreciate you doing this with me. This was fantastic. I learned a lot of new tips today. I hope you guys listening learned a lot too. And make sure that you're listening for the next episode of Skin Sync. Thanks for listening.
Thanks for tuning in to Skin Sync. Don't forget to subscribe to Skin Sync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.